This is a very big topic that Dr. Harvin and myself are very passionate about. Obviously, here in Houston, being a big trauma center for us, we get a lot of these complex cases, and we see IlluminOss as an incredible alternative to the more traditional reconstruction possibilities that joint surgeons have and that typically employ to do these cases. So the objective is to see how IlluminOss can be an alternative for acetabular stability prior to any potential reconstruction or reconstructive procedure on the hip, so hip arthroplasty. I'll let Dr. Harvin start with the case, and again, we're going to bring four cases on the University of Texas side, and again, open for questions in any moment.
So my part of this is pretty simple. I'm just the fixer in terms of the fracture. And so Dave just asked me to create a stable foundation for him to come by and do his revision joint, or in this case, this is pretty much a primary. This is a 74-year-old woman, metastatic lung cancer that was undergoing chemo, and she had AVN from chemo. She had a fall, and she has this minimally to non-displaced acetabulum fracture in combination with the AVN. The CT scans, you'll see the fracture. Really in isolation, this is minimalistic. It could be treated non-operatively. With the AVN there and her ongoing health issues, her desire to mobilize in whatever time she has left, we feel that it's a good option to do something surgical and hopefully not uberly invasive. So our plan here was to stabilize her columns and then convert her to total hip arthroplasty.
Yeah, and this, Billy, I'll interrupt you there for a second. I think important things here for this patient is that she had previous hip pain. The answer is she absolutely did. She was actually already probably on the books for a total hip, if I remember her correctly. She's a couple years out. But my question as a joint surgeon always is, what do I need to be able to do a reconstruction, to put a cup in here, right? And I always tell my trauma colleagues, and Billy is my primary trauma colleague that I interact with for these type of cases, is listen, give me one wall and one column, and if I have stability, or basically I'm putting my reamer in and I'm not seeing that I can get to a 70 millimeter reamer if I have, then I'll be able to make something happen. So I think about one column, one wall, and I'll be able to pinch something in there with screws in multiple directions. But what we've seen, and Dr. Harvin will show you now, is you're able to stabilize both columns really easily, particularly in transverse type fractures. And you'll see what we're able to perform with this technology.
So this is stabilizing the columns, doing a anterior column retrograde technique, guide wires coming in from the pubic symphysis and working it past the acetabulum, drilling over that guide wire, working into the supraacetabular bone. The advantage of this, keep going forward, Dave, with the slides, is that certainly this is a fairly straight pathway, can be stabilized with standard implants such as cannulated screws. The huge advantage of this implant, particularly in the anterior column, is that when you start converting to total hip arthroplasty and you start reaming, you're going to encounter implants. And this device can be reamed to some extent. And you're not going to have to break out trephines or metal cutting devices to work around metal implants. So it marries very well with your acetabular components.
And Billy, I think the other point there is not only can you ream it, but it increases the stability of the bone that might be thin in that area, and without that support underneath it, might just fly away as soon as you get attached to a reamer. And so I found it to be really beneficial in those cases too.
Definitely. So here we've got our anterior column guide wire in place. I'm trying to do an integrated posterior column going down the gluteal pillar into the ischium. This is okay position, but I wasn't pleased with the position completely, so I actually switched and went with a retrograde posterior column technique. I felt like we had better position of the balloon to provide support for the acetabular component. Placed our devices, cured them, and at this point, I just hand the case over.
if you look at how this turns out, I, this patient stays supine and, becomes a primary direct anterior hip with 2 screws. I mean, it's pretty life changing when you have a case like this that used to be this humongous headache, screws in every direction, terrible bone, and you're just able to get in there and put a cup like this, like it was just a simple primary hip. I know as somebody that sees a lot of these, that has struggled early in his career with a lot of these difficult cases, to see something like this is what we call practice changing. And I feel very much like this, and I think there's a lot to learn still. But a simple case, a complicated problem like this just becomes a 1 hour DA hip, which is big.
This is next case is a 40-year-old woman, Hep C, schizoaffective, fantastic patient. Had an intertroch fracture. This was treated by a partner with nailing, failed. Had an intertroch valgus IT osteotomy, failed. And then they call in our hip arthroplasty service to save the day.
Pretty protrudes to the get-go. You can tell here that they got into trouble, breached the medial wall, and what you can't expect to happen happened, probably around 4 to 6 weeks. So now we're in business here in terms of being in trouble. A patient that just calls you about 4 weeks out, says can't walk, severe pain. So this is the CT scan. Billy, I'll let you run you through your thought process when I call you for help here.
Yeah, so mostly anterior column insufficiency. This is pretty early on in our usage. I think that the IlluminOss is great because it does help stabilize the anterior column and is somewhat bone substituting. It gives you a foundation to build into. But obviously there's no ingrowth into it, but you have enough posterior column and dome for ingrowth, and this is just providing medial stability. I wasn't quite sure if it was enough in isolation, so I planned for intrapelvic plating in addition to the IlluminOss, because I was thinking I want belt and suspenders so that when you go and convert to your revision cup, that you're not going to have a problem.
Very important here, and I was part of this panel maybe 3 months ago with Paprosky and Aldo Riesgo from Baptist in Florida. Every time, to the joint surgeons on the call and the trauma surgeons on the call, every time you see a cup failed like this into the pelvis, it's an anterior column insufficiency problem. And every time you see a cup failed up and out, it's typically a posterior column insufficiency issue. Every time you see this, you assume, again, anterior column issues. So that's what we're looking for here. You can assume a posterior column that is not in terrible shape. Obviously, that's variable. And you can assume that your anterior column's gone. So when I call Billy, I say, here, give me an anterior column of some kind or some support of the anterior column so I can get something into this patient. And that's what you can see in the CT scan. Yep. Anterior column insufficiency and a posterior column that's still, semi-adequate. And that holds many times, obviously, not 100% of the time, but, pretty consistent.
No, we just did exactly what we talked about. We created a medial buttress with a plate, then IlluminOss to create that anterior column reconstruction, and then put in our pubic symphysis screws through the IlluminOss as well, increasing stability. And then I hand it back over. It's a hot potato.
Yeah, it's still back and forth. I mean, we're doing one tomorrow, right? And it's going to be a patient with a previous implant in. So we remove the cup side, stabilize the pelvis, and do we do a second surgery and come back, or do we just turn the patient over if it's a posterior approach that we need to do? That's some of the things that we still need to perfect, depending on what position we need to have the patient on. So here we have 4 screws and two, we have maybe one into the pubis there that's obscured, and 3 very good screws, in a fairly primary situation here, which without an IlluminOss, in my opinion, looking at this back, this would have been an acute cup cage on a patient that is, if I'm not mistaken, in her 50s. So this gives her a very good potential for biologic ingrowth into this cup and a very durable implant. I think she might be maybe 2.5, 3 years out now. So,
Dave, what do you think the advantage of this over cup cage is? Because that's what we're saving.
sure. I mean, cup cage, you're cementing a liner into the cup cage, so we can argue all day about the durability of a cemented liner in versus this potential biologically ingrown uh, cup with either dual mobility or this looks like a 36 head, maybe non-dual mobility. Actually, this might be a dual mobility. I just can't see it very well. But the durability of this for me is the potential for ingrowth of this cup and just a regular wear rate of a total hip arthroplasty.
Got it.
We can argue that the cup cage with a cemented liner in doesn't necessarily have any potential for ingrowth. You're just bridging the situation, and you're just hoping that it holds on for a long duration of time in a young patient. I think it's a lot to ask.
Are you allowing your patient weight bear immediately after this procedure?
I've always been you don't lose anything by touchdown weight bearing complex reconstructions for 6 weeks. I'm a strong believer of that. I even on the early phases of us doing this IlluminOss combination with acute arthroplasty, I've touched down bear weight all these patients, but I don't see, now looking back with the reconstruction that we were able to do, why we did it. But it's much more of my history of what do you lose in a patient like this, letting them touch down bear weight for 6 weeks, taking it easy, taking it slow, letting the cup in grow a little before you stress it. I don't think you gain much by just allowing them full weight on this particular, complex reconstruction. But
I think you're talking here like at 50, that's very true. But I think if you were talking about 70 or 75, I think we're having a different conversation, right? Because we do know that sarcopenia and things like that, muscle wasting starts immediately. So whatever we can do to get these patients weight bearing as quick. And I bet had you let that patient weight bear, that probably would have done great as well either way. So I think you guys did a great job.
Hey, Dr. Rodriguez, quick question. So to unitize this construct in the location where the shell is contacting the IlluminOss, do you cement in that small interface like you would for an augment? Or do you find that you don't need any cement at all?
no, I'll tell you, you look at your contact points here on this cup, and you're probably looking at 80%, bleeding bone contacting your cup versus 20% actually touching the IlluminOss. I actually feel like it's a good idea, but I think you have more than enough surface contact into your porous coated cup to allow for ingrowth. So we haven't done it. I think that it's something that we could consider if the defect or the IlluminOss is a higher percentage of the contact points. But I mean, you here probably are looking at 80-85% contact, and as you know, and this is a very familiar voice, by the way, this might be DA, one of our previous residents. As you know, you only need 30-40% ingrowth for this cup to become a stable construct.
Fabulous. Thank you.
All right. Let's go on to the next one, Dave.
All right, here we go. Billy.
I'll try to go quickly. This is an 83-year-old man, prostate cancer, radiation and hormone treatment, no surgery, started developing groin pain. His slides show that he's got a pathologic acetabulum fracture. And honestly, that right there is an ideal situation for IlluminOss. Even, I know this is traumaplasty, but by itself, you got a non-displaced acetabulum fracture, and with METs, I mean, that could have been done right there to stabilize his fracture, make his pain, and keep him mobile. It wasn't.
We didn't have the patient at this time, correct?
No. This was treated by another physician. Ultimately, he had this fracture. He underwent a total hip for pain. And the reamings and curettage were sent to pathology and were negative. He was touchdown weight bearing because it was into pathologic fracture. This was not our case at this point. Keep going forward. So this is September. This is October. He's kept non-weight bearing.
Yeah, this right-sided X-ray now is the newly onset pain, and you can see a difference here in the anterior column between the image on the left and the image on the right.
And then Christmas, December, he's continually needing more narcotics, more pain, still non-weight bearing, and clearly something is not right. And then this cup is just keeps on subsiding. The fracture is getting worse. At this point, he's going to get referred to us for
Again, this
treatment.
this holds again, failing inwards. Anterior column is about to fail. Posterior column still there. So that continues to hold very well.
And it just keeps getting worse.
Yeah.
Now, there's a 3D after this that really shows the protrusio, both medially through the quadrilateral surface and superiorly through the anterior wall and column. So again, at this point, plan is to take everything out, stabilize the anterior column, recreate bone stock in the anterior column. Exact same principles that we just discussed. This time we did an antegrade and we did posterior column fixation. I do believe there was some involvement in the posterior column as well.
And I don't think there's anything wrong with stabilizing the posterior column because we're going to be reaming, in complex reconstruction, as most on the call probably know, is you're relying on the column that you have that's stable, it's not compromised. So I'm going to be relying on my posterior column in this case for my cup fixation more than anything. So I'll be okay with even prophylactic stabilization just to have more support, even if we don't necessarily call it a posterior column or call it posterior column involvement. I'm perfectly okay with you doing both, like you're doing tomorrow for us.
Right. Honestly, in isolation, this is probably enough. This is early on in our experience. I wanted to go and belt and suspenders and provide absolute stability. And we did intrapelvic plating again and then passed it back to David to convert to his revision cup.
So I'll tell you this: you know what us arthroplasty surgeons feel about inferior cup fixation. You see me when you see me not put inferior screws, means that cup was solid, right? So I'm made fun of by my colleagues about too much, screws into the pubis, too many screws into the ischium, or at least trying. You've seen these cases without inferior column fixation or inferior fixation in the cup. I mean, it's just, again, practice changing the things that that's given us in terms of fixation and stability for the cup. So I don't know. He's out maybe 3 years out now. He was able to bear weight right away. We did allow him. This was a little bit further out, so we allowed him to bear weight right away.
No, I think this is at 6 weeks, I recall, and this is a guy that hadn't walked in a year.
Yeah,
That's incredible.
Yeah.
Incredible. So, Billy, technical question for you. If you go back, so prostate cancer, oftentimes can have these mixed lytic and sclerotic lesions. And actually, the only time a couple weeks ago I tried an IlluminOss, and I had a really hard time passing my guide wire to even get a reamer in. I was trying to do a posterior column screw along the gluteal pillar, and I was having a hard time getting in through those mixed sclerotic lesions. Any tips or tricks for bypassing those? It looked like maybe you were using a little different wire.
I mean, I usually use like a standard cannulated screw wire and drill. So drilling rather than passing a ball tip, I like to do. Obviously, when you start to make turns, there's only so much you can do with that technique. And the other thing is if that's the case, I then would maybe try to do it through a different technique in terms of instead of doing anterior coast posterior column, maybe trying a retrograde posterior column.
Yeah, so start thinking more traditional straight corridors that you can place more straightish implants.
Yep. This is the last case that we had. This is a relatively younger woman. I think she's 60 or less. I think she was a dysplasia patient. That's why she has all this surgery. David did a revision surgery for her, and unfortunately, she was pushed down by her husband and fractured through her anterior column.
Vision for it was for instability, liner there, which is not necessarily a mistake always, but it wasn't this particular case. And again, what would we do in this particular scenario? Same concept, what we've seen. Those will be a cup cage or tri-flange all day.
Yeah.
Mm.
This is probably the first one we ever did. So
Yeah, this was the first one, actually. You're right.
yeah. Stabilizing the anterior column with the IlluminOss. You can actually, if you go to the CT, which I believe is next, you can really see the IlluminOss starting in the ilium right about now. And there's some coils going through the supraacetabular bone, through the acetabulum into the pubic symphysis. And then at this point, everything's stabilized. We flip her up onto her side and do the posterior approach. And this is what we find. Her head is to the top of this picture with her foot towards the bottom, the posterior walls on the left, anterior walls on the right. So this is going through our acetabulum. And David starts to ream.
I started this reaming with a burr and then, created my shell. So after bone grafting, we still have a lot of bleeding bone, from 12 o'clock, as you can see, all the way down to the Homan and the operator foramen. And again, really happy with the fixation that we were able to obtain. Obviously, we went jumbo on her, trying to obtain as much contact as possible. So, this is our goals in traumaplasty. Again, restore column alignment and stability, create a stable foundation, and implant more conventional less tabulated components with longer durability. I think IlluminOss on these series, and hopefully we're able to write this fairly soon. I think we have enough patients now for a case series with good, adequate long-term follow-up to share it with the world, and hopefully, it starts to allow for more, more durable constructs, and trying to shy away from cup cages and tri-flanges that we tend to rely on when things get out of the ordinary. And I think IlluminOss can help us with that.
Okay. Yeah, we got a couple cases to show. Again, it's really Dr. Harvin, Dr. Rodriguez have kind of covered, I think, the gamut of what this can do. But just to show you that it doesn't, you don't have to have an expert trauma surgeon. You just have a sort of okay trauma surgeon and a very good arthroplasty surgeon and still have good results with this technique. All right. So our first case, this is a very complex case. Let Dr. Thakral talk you through how this 96-year-old lady presented.
Well, this lady apparently had been on wheelchair for more than a year, 6 months, been getting worse, and 96, but reasonably healthy. And her aim is just to get up, mobilize, and be in no pain. That was her goal, and you can see her age. So what do you do here? My original thought was decompress everything, get a 3D recon, build up here and see what bone is left, what's going on. It's a big osteolysis and implant, which is done in early 90s, I believe, 30 years plus. And trochanter is broken. She was miserable. And with a long discussion with the family, what do you do in this case? I also gave her an option of a girdle stone, just take everything out because this was getting worse. I believe when you have osteolysis going on, there's a microfracture which continues to go on. And those small little discomfort kind of cause a lot of pain for the patients. So nobody in town will tackle this problem until she arrives. And I had a discussion with Dr. Hull and what should we do to help her.
Yeah, and this was one of our first experiences with IlluminOss at Oklahoma. And yeah, so she's been to multiple surgeons in the community, and everyone has come to the conclusion, I'm sorry, you're 96, there's nothing we can do. So infectious workup was completely normal. These are her representative CT cuts. So not only does she have significant bone loss from the anterior column, but she really has a lot of bone loss from the posterior column as well. So stability in this case is really challenging. And even thinking, what do you do? Could we do an intrapelvic approach and plate it? Yes, we could. Could we do a posterior approach? I don't know that we're going to get meaningful fixation from our screws along our posterior column. And so IlluminOss really, we felt like it was a game changer for us in this case. And so as you go through these and identify all of the problems that she has, loose acetabular component, we know we're going to have to revise that. She's got all this extensive bone loss. She's got the greater trochanter fracture. And then there's questions of her having actual instability within the cup itself. You can see the eccentric polywear. And so we made the plan to try fixing this with IlluminOss first and then revision arthroplasty after that. And so again, just walking through our technique, this is now you see that instability that we talked, the questionable instability turns out it's definitely there, right? You see your hip dislocated. And this is us starting with the posterior column approach, the iliac oblique, and we just look for that thickest part of the gluteal pillar there, and then I go to an obturator oblique from there to do opening reamer, and you can pass your guide wire, blunt ball tip around the corner, snake it down the ischium, followed by your flexible reamer. That's the switching stick component, and there's your deflated balloon. You can watch the balloon inflate, and it filled that space really nicely. And then again, with a retrograde anterior column wire, a second balloon was passed. And with those two balloons cured, Dr. Thakral was able to do a really nice kind of cemented revision here.
So the thought here was the age factor. What are we trying to achieve here? And I had everything backed up from multi-hole cup augments and everything. Opening up the hip. This is one of our early experience. So we did turn the patient around in lateral position. And again, the thought was we could still be able to do a stage procedure if we cannot fix. And of course, this is a lady who cannot have multiple surgeries. Going in, looking at the shape of the cement, the way it expanded around, this sort of required a lot of augment, a lot of stuff, and bigger cup. And there was a lot of cavitary lesions. I had to really debride a lot. And we took a lot of cultures. Thankfully, all came back negative. So this was a thought to cement it in and call it like a partial stage, which can give her a good support and be pain-free. And I could manage to drill a lot into the IlluminOss, like so that cement can go on like pseudopods. I did train in UK and Ireland, so of course my old training skills, which we used to cement some cups, not anymore, but that's something kind of I applied here and managed to put some holes into the IlluminOss very nicely and fixed very well and held the cup position in a way we can get the best position and use a large head and of course fix the trochanter. And I'm one of them who uses some allograft in that fracture site, and it supported very well. And to our surprise,
so these were immediate post-op films, and this is her just before her 3-month follow-up. And if I'm gonna fast forward a little bit through your patient information portion, but if you listen to her,
That's awesome.
the patient tells you right there she's having no pain, and this is a 96-year-old who hasn't walked for over 6 months, been in a wheelchair for a year, and truly just an incredible result. Our second case here is a kind of the opposite side of the spectrum. So the last one was 96. This lady is 42, and she presented to my tumor partner's clinic on a Wednesday and had these x-rays. And so he started the new bone lesion workup on her. She's had, pain for the last month or two, and she's starting to progressively be unable to put weight. And so he makes her non-weight bearing with plans to complete that workup and then plan for arthroplasty. So we're not going to go through all of the arthroplasty or the oncology workup, but he made her non-weight bearing. But surprise, nobody. She shows up in our ER 2 days later looking like this. And so just was rising from a toilet and felt a pop. And so that workup got expedited a bit. And here's her representative CT cuts. Get those screaming. I'm sorry. Play here. And, I was concerned about her posterior wall and a lot of significant bone loss kind of in the posterior superior aspect of her acetabulum. And so we had augments available and ready for her when we took her back for her arthroplasty. But with the LC2 IlluminOss and anterior column IlluminOss, we were actually able to put a very stable primary total hip in, and we actually let her weight bear immediately because we felt like it was really important for her to be able to walk. And she also, if you notice, if you guys look back, there's a lesion in her proximal femur on the right. So 3 days after her arthroplasty, we did a prophylactic nail on the right side, and that's her 8 weeks. I don't have video of her walking, but she was walking unassisted at 8 weeks and doing really well.
Do y'all
Go ahead, Billy.
remember how much of the acetabulum when you reamed was there, or how much IlluminOss you saw versus acetabulum?
Yeah, so I would say 3/4 of her acetabulum was there,
Okay.
uh, but
Yeah.
we were missing I mean, almost from 12 o'clock to about 3 o'clock or 4 o'clock, not superior, posterior superior.
Sure. Yeah.
Yeah. And the other thing I would say is that the bone, as you got more anterior, was thin. So as you reamed, that's where I worry that if we hadn't had something supporting that subchondral bone, that might have flown off in the reamer. We may have ended up with a pretty large defect anteriorly as well, had we not had that support.
Yeah, that posterior superior tumor on the acetabulum would be a big problem without some level of support like IlluminOss gave you here. And I think one thing that obviously is still to be determined that I wanted to discuss is if you wanted to cement a cup in here in the presence of tumor, nobody would fight you about that, right? You have lower potential for ingrowth on patients with a tumor in the acetabulum. I think IlluminOss provides a very, very good scaffold for cementation, with the irregularities that it brings into the shell portion. So this is phenomenal. It does have areas without tumor that do have potential for ingrowth. Let's say you had a full tumor acetabulum where everything is just bad, and you have IlluminOss in, like you showed in the previous case. Phenomenal scaffold for cementation as well, both in infected cases and in cases with poor potential for ingrowth.
Yeah, this is amazing technology. I think, as you mentioned, a lot of time you can do a cup, even if you have 60% contact, there'll be some ingrowth, especially in this case, other than the part which is in the luminous area. But this is a solid fix in my mind. And as this example also illustrates, weight bearing straight away.
Yeah.
And as we're evolving and learning from each other, I think there'll be more to come. And we were just talking about it, like a lot of time you would read that part which is bad, let's say from osteolytic disease or is from the tumor. To breed that and then put the luminous and how to clean that up, wash it out well. Could be something like a perk technique we could evolve on. That'll be something I was thinking about throughout the time since my exposure on this device. Any questions anybody has?
We have 5 minutes for questions if there's any.
Yeah, thank you guys so much. Those are awesome cases and awesome presentations, and it's great to hear how well your patients are doing with this. I'll just start off a question on the tripod or the LC2 and the column fixation. With regard to the posterior column, how do you decide whether you want to go antegrade or retrograde, gluteal pillar versus ischial? Is that patient positioning or just with the access? Do you always go from the top down, Dr. Hull?
Yeah. So full disclosure, trauma surgeon trained, we never did retrograde posterior column screws. So that's a technical probably failure on my own part. But the other thing I think about is you want, because you can do a traditional posterior column screw and go off the inner table, right, to get that still same straight trajectory. I think the question for me is I want to have bone stock both proximally and distally to anchor the balloon into. And so that way it's not just floating. And so I think whatever approach is going to give you that for me.
So Brandon, I used to do the same thing until my partner just said, just go do this. And because I was like, I don't know where the sciatic nerve is, blah, blah, blah. it is lateral, and going retrograde is actually super easy. I do it all the time, and um, it's very easy to do. And I think you should try it, and it's very easy.
So
Uh,
whenever when a D gets here in the fall, he's going to come well trained. He's going to teach me how to do it.
um, but
Still to
doing
be determined if he goes, I'll tell you. I'm just,
doing the antegrade posterior column is hard. Sometimes, number one, the gluteal pillar, depending on what implants you're using, isn't always huge. Two, turning the corner and getting really down low on the ischium can be hard. Um, you know, this we have a guide wire, you can put a bend on it.
Using IlluminOss to create stability in the acetabulum, DA versus posterior approach. What are the challenges, one versus the other, or is all the experience with direct anterior for you?
yeah, I mean, I'll answer it. I think as somebody that does both anterior and posterior revisions, to me, every time I see posterior column insufficiency, it's hard for me to think about doing it from the front. I worry that I won't be able to do the right reconstruction if I'm not in a posterior based approach. That might not necessarily be accurate in different hands, but if we're seeing the cases that we showed that it's mostly an anterior column problem, now with the osteotomy techniques of the ASIS and the AIIS, where you're able to access the inner pelvis, and with Billy there as well, giving me, very much interpelvic access without, me being able to feel super comfortable with those things necessarily. We should be doing this from the front if it's an anterior column problem. That takes away the flipping around back and forth, right? And I think that would come with us growing more and more into utilizing IlluminOss. If we're able to tackle most of these from the front, I think it'll be a lot less flipping of the patient, and that's my goal in the future. There are cases like the last one that we showed, where there was a lot of posterior column insufficiency. I was just not sure that I was going to be able to do it from an anterior approach. So that one got the flipping treatment. But if we can do everything from the front in an anterior based approach, that'll be a big win.
Yeah, I echo with you, Rodriguez. That's how we've been thinking of as well. If we can get a sense like how and what patient to select to go anterior or versus posterior. I also worry if there's a posterior column, especially with a hollowness we have, like a stub pipe in the back. There's nothing in there. How do you address that from the front? That's a big challenge. But this technology has made it possible, I think, and we could approach it anteriorly once that's stabilized with the Luminos.